Hi, my name is Dr. Sherry Gibson. I'm a licensed psychologist specializing in aging, or what the field also refers to as geropsychology. Thank you for joining us today in this very important collaborative effort between the National Consumer Voice and the Long-Term Care Ombudsman Resource Center in providing you with a four-part webinar series targeted to long-term care communities, administrators, direct care staff, and families of residents living in long-term care. This webinar is focused on trauma-informed care in a time of COVID and has been created for direct care staff in promoting healing of residents. As you all know, the coronavirus has infected millions of people and has killed tens of thousands across the globe. A vaccine is perhaps a year away, and the long haul we face begs the question, how will people respond to and bounce back from adversity as the pandemic waxes and wanes? What will a post-pandemic world look like, and will our society prove to be a resilient one? While scientists are continually trying to understand the multiple layers of physical illness associated with COVID-19, the stressors associated with the pandemic are also likely to have serious mental health consequences. It's quite normal to experience distress as a result of chronic stress of this magnitude. Losses are real. For example, the death of family members or loved ones without the opportunity of a ritualized funeral as we once knew. And losses are also symbolic. Not being able to attend graduations, not missing out on Mother's Days or Father's Day celebrations, important milestones, anniversaries, and other things that are coming and going without being in communion with one another. And grief for many is experienced, as well as unresolved grief. There will be no one size fits all in terms of the response to this crisis. Individual responses then are multifaceted, and I believe are impacted by two important factors here. One, the pre-pandemic circumstances and resources that were available to people. For example, did people already have a prior exposure to adversity or to trauma? What was their physical and mental health vulnerabilities prior to the pandemic? And was there a lack of or availability of economic and social supports? The other factor is the exposures that have been encountered since the pandemic. For example, illness or even the death of a loved one, the loss of job or health insurance. Job status is an important factor. For those of you who are viewing this webinar, essential healthcare workers, the fear or anxiety that is experienced when you're providing care day in and day out with the possibility of exposure to this deadly disease. And the time immersed in social media or news and overexposure to information, the constant barrage of negative information can take its toll. And then also the community level stressors. For example, are you in one of those communities that were identified as a hotspot? Did shops and restaurants close, never to reopen? Was there ambiguous responses from your state's governor that was backed by the best science? The emotional and behavioral responses to this ongoing crisis will be multi-determined, but are not random. That means that psychological science has isolated the risk factors that can guide healthcare providers and social service organizations to identify the most psychologically vulnerable among us. So when we talk about trauma response, I'm referring to not only residents and families that you're charged with, but also among you as staff and the administrators who lead in communities of care. SAMHSA, which stands for the Substance Abuse and Mental Health Service Administration, has done a lot of research and has provided tons of resources and writings on trauma-informed approaches to care. And three major themes that they have highlighted is that behavioral health services are essential to overall health and well-being of people, that prevention does work, and that treatment is effective in addressing trauma. The core elements of trauma-informed care is that we have to understand first the prevalence of trauma in order to recognize how trauma impacts people at the individual level. And then we put that knowledge into our practice so that we can actively resist the re-traumatization of people. This could never be more important than where we find ourselves now in this pandemic. And when I think about the re-traumatization piece, I'm acutely aware of how traumatizing just the act of quarantining or being confined to one's room or a small space has on a person's mental health functioning, and how that can re-traumatize a person by that very act, the cutting off from very important family or other social supports by virtue of having to be confined or quarantined. In the mental health field, we have different ways of understanding trauma. And always the underlying question has been, what's wrong with you? We must make a shift now to ask what's happened to you and see symptoms as adaptations to traumatic events and experiences, and know that healing happens in relationships. I want to share with you now a video that's been provided by, and it was a talk given by Brene Brown, who is a known sociologist and who's studied and given talks on vulnerability. But I believe this video, this very short video, highlights the differences between empathy and sympathy. So please watch this now.
So what is empathy, and why is it very different than sympathy? Empathy fuels connection. Sympathy drives disconnection. Empathy, it's very interesting. Teresa Wiseman is a nursing scholar who studied professions, very diverse professions where empathy is relevant, and came up with 4 qualities of empathy. Perspective taking, the ability to take the perspective of another person or recognize their perspective as their truth. Staying out of judgment, not easy when you enjoy it as much as most of us do. Recognizing emotion in other people and then communicating that. Empathy is feeling with people. And to me, I always think of empathy as this kind of sacred space when someone's kind of in a deep hole and they shout out from the bottom and they say, I'm stuck, it's dark, I'm overwhelmed. And then we look and we say, hey, I'm down. I know what it's like down here, and you're not alone. Sympathy is, ooh, it's bad, no, you want a sandwich? Empathy is a choice, and it's a vulnerable choice, because in order to connect with you, I have to connect with something in myself that knows that feeling. Rarely, if ever, does an empathic response begin with at least. And we do it all the time, because you know what? Someone just shared something with us that's incredibly painful, and we're trying to silver lining it. I don't think that's a verb, but I'm using it as one. We're trying to put the silver lining around it. So I had a miscarriage. Oh, at least you know you can get pregnant. I think my marriage is falling apart. At least you have a marriage. John's getting kicked out of school. At least Sarah is an A student. But one of the things we do sometimes in the face of very difficult conversations is we try to make things better. If I share something with you that's very difficult, I'd rather you say, I don't even know what to say right now. I'm just so glad you told me. Because the truth is, rarely can a response make something better. What makes something better is connection.
I really appreciate this video for a few reasons. One, when I first saw this video, I had an awareness of how many times I might say at least somebody. And it really raised my awareness to how that isn't helpful, and that we are oftentimes moved to want to fix something. And many times people don't need that fix, but what they do need is our empathy and just listening and understanding. So trauma, by definition, results from an event. And the focus on event places the cause of trauma in the environment, not on some defect in the individual. This is what underlines the basic credo of trauma-informed approach. It's not what is wrong with you, but what has happened to you. And so that event or series of events or set of circumstances is experienced by an individual as physically or emotionally harmful or life-threatening. I've underlined experience here because it highlights the fact that not every child or adult will experience the same events as traumatic. And those events has had a lasting adverse effect. And effect is important here because the identification of a broad range of potential effects remind us that our response must be holistic. It's not enough to focus on symptoms and behaviors. Our goal is to support a person in learning and growing in order to live that satisfying life. And so again, knowing that those effects are on the individual's overall functioning, mental, physical, social, emotional, and spiritual well-being. I've listed here potential traumatic events that are kind of categorized into these three categories: abuse, which most of us are familiar with, loss, and chronic stressors. Chronic stressors often get minimized or overlooked. And those include poverty and racism, an invasive medical procedure, community trauma, historical trauma like genocide, for example, or somebody who's lived with a family member with either substance abuse or serious mental illness. And I would suspect that in this time of our history during a pandemic, that we are also looking at the chronic stressor that is in front of us, as this probably isn't a short-term situation, but that will be a long haul. And so the stress of being quarantined, the stress of going in and out of quarantine, reopening places and then closing them back, that will be its own chronic stressor. In terms of the prevalence of trauma, exposure is ubiquitous. 7 out of 10 respondents worldwide and 9 out of 10 adults in the US report experiencing one or more lifetime traumas. It's important too to understand that psychopathology in response to trauma represents a consequence of the complex accumulation and interaction of life experiences that range from social to biological factors that occur over a lifespan, from gestation to death and across generations. So trauma can be cumulative. Trauma also has an impact on the brain. If you will, the brain can be thought of as a bottom-up organization. So the bottom regions of the brain, such as the brainstem and the midbrain, control the most simple functions such as respiration, heart rate, and blood pressure regulation. The top areas called the limbic or cortex, control more of the complex functions, such as thinking and regulating emotions. At birth, the human brain is underdeveloped. Not all of the brain structures are organized and fully functional. During childhood, the brain matures and the whole set of brain-related capabilities develop in sequence. So for example, we crawl before we walk and we babble before we talk. So that development of the brain during infancy and childhood follows that bottom-up structure. And you can see here that when our brains are underdeveloped as infants or children, if we experience some kind of adverse situation or trauma, that then disrupts our neurodevelopment. And it disrupts the normal development of our brains. That can lead to social, emotional, and cognitive impairments that then lead to an adoption, if you will, of health risk behaviors, such as it can range everything from smoking to promiscuity to gambling, drug use. That then leads to disease and disability and social problems, and oftentimes early death or premature morbidity. So therefore, the effect of trauma on an individual can be conceptualized as a normal response to a very abnormal situation. Most of you, I suspect, are familiar with the fight, flight, or freeze response. These responses are activated by danger. Some common behaviors of trauma survivors, behaviors that are often labeled as problems by the mental health system, can be linked to these responses and to the effects of trauma and the effects that trauma have on the brain. This list, or this slide rather, lists 3 sets of those problems that are often attributed to people in the mental health system and shows how the behavior might be a survival mechanism tied to a fight, flight, or freeze response. First is the fight response. And in the mental health system, someone who struggles too hard to hold on to their personal power may be labeled as non-compliant or combative. Second is the flight response. And in the mental health system, anyone who emotionally withdraws or disengages too much may be labeled as treatment resistant or uncooperative. And third is the freeze response. Anyone who gives in too easily to authority may be labeled as passive or unmotivated. I like to refer to this one as the bobblehead response. I'll agree with anything you say just to get out of this situation. Many of the people we serve and you serve have survived circumstances that we can hardly imagine. What we often label as pathological may be the very things that helped those people survive. When we take a trauma-informed approach to our care, we recognize symptoms as problem behaviors, not as problem behaviors, but as adaptations to trauma, frequently including the feelings of helplessness and loss of control that trauma often causes. I've listed here some additional signs of a trauma response, including flashbacks or frequent nightmares, a heightened sensitivity to noise or being touched, always experiencing something bad to happen or expecting something bad to happen, maybe not remembering periods of one's life or feeling emotionally numb, lack of attention and concentration, irritability, and excessive watchfulness, anxiety, anger, shame, and sadness. Each of these behaviors, again, can in fact play an important role in this person's life. They may protect the person or help them to survive. So I want to switch now in how we take the information that I've just gone over and we put it into practice in a trauma-informed care approach, particularly during a time of COVID-19. The trauma brain results in dysregulated behavior. So as residents' anxiety increases, their thinking brains become less engaged and behavior becomes more dysregulated. You have the ability to develop skills to help residents regulate and relate by becoming calmer and more connected with them. And that's achieved by some very basic skills: warmth and validation of how they're feeling, flexibility around your care and what they need in that moment, providing structure to a day, statements of hope for the future. The use of humor goes a long way, and letting people feel and being a part of a connected community. There's no better person to do that than to you. And for you to be calm and regulated is also critical. So what kind of skills can you develop in order to provide trauma-informed care? I'm going to go through some important skills that I think apply to your work specifically, and things that you can do in order to be better providers in keeping trauma at the center of your care. So we know that people who have experienced traumatic events, particularly at the hands of a caregiver, were given contradictory messages. They were dismissed or ignored, silenced, abandoned, shamed, told that they had no rights. You have repeated opportunity to offer corrective, positive emotional experiences to the people you serve. So how I've structured these slides is so that you can embody these statements as I statements in order to develop skills that are important in your care of residents. So you need to know when you're feeling tired, angry, sad, frightened, and be able to read nonverbal and emotional cues of other people. Understand what they're saying through their eye contact and facial expressions, their tone of voice or their body posture, movements and gestures, the rate and tone of their voice is really important. Did you know that 85% of all communication is nonverbal? So it's really important for you to pay attention to what people are saying through their behavior. Know that you're able to verbally reflect another person's emotional state. For example, it sounds like you're feeling angry about this. And after reflecting that feeling, being able to validate that emotion. I've provided an example here. You had to wait 3 days for me to return your call, and your question is really important to you. I understand why you're mad about this. Another skill is being able to regulate feelings. One significant outcome of having an overwhelmed nervous system is emotional dysregulation. And this can make it harder to use skills learned in the past. Dementia, for example, can also undermine accessing skills to regulate emotions, or if people are having a psychotic episode secondary to a mental illness diagnosis. So here's what you can do. Know when you start feeling overwhelmed and know how to bring yourself back into an emotional balance. What do you do to do that? Do you take deep breaths? Do you go for a walk around the community, the campus? Know what it is that you do, and know that you can then be equipped to engage others who are experiencing overwhelming feelings. You're able to help them manage those feelings. Be aware of different grounding strategies for people. One that I often do is if a person is very dysregulated, perhaps they're crying or sobbing, or maybe they're very angry, I'll ask them in a very calm voice to look at me and take deep breaths along with me. You might ask them to kind of get back into their body, shrug their shoulders, sit up straight, redirect their attention to something more pleasant. Another skill is understanding that stress response, the flight, fight, or freeze response. That nervous system most important function is what keeps us alive by alerting us to danger. Many people, however, who are under or over responsive to even the slightest perception of danger may engage in behaviors that include violence, running away, self-abuse, or shutting down. It's important also to have open and respectful communication. Many trauma experiences are dehumanizing, leaving people feeling shameful or internalizing that judgment. Staying away from judgmental or clinical language can help to not reinforce those beliefs. That kind of language allows staff to put clients in an other category. This person is different from me. It's an us and them, and that's not what we want. We want to have open and respectful communication. That type of distancing can prohibit the formation of a therapeutic and healing relationship. The other piece is appreciation. That survival brain becomes preoccupied with pain and danger, but can be distracted when redirected and reminded of other things such as pleasure and fun, security and belonging, joy, beauty, and humor. Know that you have a deep connection to things that are important to you, and know that most of the time you believe that your life has purpose and meaning. And when you understand that about yourself, you're also able to talk to other people about what makes them unique, and you can help them connect with activities that promote a sense of hope and value. Trauma-informed care really puts the relationship at the center. You don't have to be a therapist to be therapeutic, and you have multiple opportunities throughout your day in which you can create a healing space in that relationship. And that happens by understanding the prevalence and the impact of trauma on people. You also can promote safety and earn the trust of the people you care for. Embrace the diversity of experiences and responses. Provide holistic care, respecting human rights and pursuing the person's strengths, choice, and autonomy. Sharing the power. As a care provider, you hold the power when you walk into a resident's room. The way that we balance power in any relationship is that we stop talking and we allow the other person to share. When we be quiet and listen, actively listen, we share the power. Communicating with compassion. All of these are so important and vital in healing. And remembering, just as I mentioned in the person-centered webinar, that trauma-informed care isn't something that we clock in and we start doing. We live with a trauma-informed approach to every single person we encounter, every single relationship that we have. It is a philosophy of how we engage with others. And when we see behaviors that may seem problematic or not logical, we have to ask ourselves, is this a trauma response? What is it that I'm seeing? And become curious about that so that we can provide empathy and compassion to people where they are. I want to thank you for being a part of this webinar. I've included some resources here for you for further reading. I recommend the last one listed here, The Body Keeps the Score by Bessel van der Kolk. Very informative, great, lots of great information. I've also included resources that you can find through the Consumer Voice and the National Long-Term Care Ombudsman Resource Center. Here are the websites for both of those organizations where you can find lots of great resources, and you can also connect via social media. Thanks again for joining us for this webinar series, and I wish you the best.